Hello, Psyche community, and welcome to today's webinar, Neuropsychiatric Symptoms During COVID-19. Thank you so much for joining us. My name is Dr. Chloe Liu, and I am a medical science liaison from the Otsuka Field Medical Affairs team. I will serve as the moderator today for today's discussion, featuring Dr. Cummings and Dr. Grossberg. Dr. Jeffery Cummings is the founding director of Cleveland Clinic Lou Ruvo Center for Brain Health. He is a Joy Chambers-Grundy Professor of Brain Science, Vice Chair for Research, Director of Chambers-Gundy Center for Transformative Neuroscience, Department of Brain Health, School of Integrated Health Sciences at University of Nevada, Las Vegas. Dr. Cummings is an expert clinical trialist and a leading figure in the drug development for Alzheimer's disease. He has published over 750 peer-reviewed scientific articles and 40 books on Alzheimer's disease, clinical trials, and related topics. His achievements have been recognized by many awards. Dr. George Grossberg is a Samuel W. Fortas Professor at Department of Psychiatry and Behavioral Neuroscience and Director of a Division of Geriatric Psychiatry at St. Louis University School of Medicine. Dr. Grossberg holds membership in several professional societies. He appears regularly on lists of top doctors. Dr. Grossberg has edited or written 15 books and published over 500 articles, chapters, and abstracts in the peer-reviewed literature. He is a consultant in the development of protocols for central nervous system disorders in elderly patients and is involved in a variety of basic as well as clinical research projects in the area of dementing disorders with a focus on behavior disturbances in Alzheimer's disease. Today's presentation is sponsored by Otsuka Pharmaceutical Development and Commercialization Inc. and Lundbeck LLC, committed sponsors of the mental health treatment community. The speakers are paid consultants for Otsuka Pharmaceutical Development and Commercialization. The information provided during the program is being brought to you by Otsuka Lundbeck, who have a collaboration with Open Minds in an effort to bring increased awareness to mental illness. It is intended for your educational benefit only. No CME or CEU credits are offered. It is not intended as, nor is it a substitute for medical advice or care or professional diagnosis. Users seeking for medical advice should consult with their physician or other healthcare professionals. Our speakers aim to provide you with information that is accurate, not misleading, scientifically rigorous, and which does not promote Otsuka products. We may not be able to discuss every topic that you're interested in, but we'll do our best to provide open communication. Regarding communication, you may notice that all attendees have been muted. We're recording today's event, and muting all phone lines assures the highest quality of sound. Due to time limitation, we will not be holding a live question and answer session at the end of the presentation, but please do submit questions via the question box on the GoToWebinar panel at any time during the presentation. The speakers will address them later in a separate podcast. Without any further ado, Dr. Cummings, would you like to walk us through the objectives for today's discussion?
Thank you, Chloe and George. It's great to be with you. We're really not in the same room. We're doing this virtually, as all of our participants are. Thank you for watching this today. It's really great to be with you in this virtual way. And of course, we're addressing COVID, and COVID is affecting all of us, and more importantly, it's affecting all of our patients, including their neuropsychiatric issues that have arisen in the course of their disease. So our objectives today are to discuss a hypothetical case constructed by George to discuss the neuropsychiatric symptoms of patients in a residential facility in the time of COVID, and to discuss the impact of COVID on patients with dementias and their families and caregivers. The effect has been profound. And we'll have a brief introduction of neuropsychiatric symptoms and their management in different care settings during the COVID-19 pandemic. George, can you take us through the case?
Absolutely. Thank you, Jeff. And it's great for me as well to share this virtual platform with you. And hopefully this will be enjoyable and educational for all of our virtual observers. So this is a hypothetical case. Mr. K.A., who's a 65-year-old gentleman. As you can see, he has a history of early onset Alzheimer's disease, which was diagnosed a couple of years ago, back in 2018. He also has a variety of other medical problems, which are not rare in this older adult patient population, including osteoarthritis, hypertension, hyperlipidemia. He has obstructive sleep apnea, which, Jeff, I think, as you know and are aware of, is a potential cause of or a contributing cause to cognitive impairment, COPD, gout, and then recently, after his diagnosis of early onset Alzheimer's disease, he was diagnosed with AFib, with atrial fibrillation. In December of this past year, so literally less than 12 months ago, he was placed in a nursing home after a hospitalization for his AFib. He, as I mentioned, came with the diagnosis of mild Alzheimer's disease, but one of his other issues was that he was not taking his medications properly for all of his general medical problems. Unfortunately, his wife, his spouse, has her own issues, medical and otherwise, and was really unable to care for him. And because of that, he was placed in a skilled nursing facility, in this case in Missouri, because the family could not afford assisted living or memory care. And this is an interesting phenomenon that in many states, including my state, if you are indigent or qualify for Medicaid or state aid will pay for a more expensive nursing home, but will not pay for a less expensive assisted living or memory care kind of environment. So often patients don't have much of a choice, and Mr. K.A. fit into that category. So he arrives at the nursing facility, and geriatric psychiatry consultation was requested for evaluation of what was quote unquote cognitive impairment and mild anxiety. These are not uncommon reasons for geriatric psychiatric consultation. We were able to look at his medical and psychiatric history, and the good news was, he had recent labs, including UA, metabolic profile, blood count, TSH, vitamin levels, including vitamin B12 and folate and D, and these were all within normal limits. He had had a recent brain MRI, which showed some fairly common findings of central and cortical atrophy and small vessel disease, but nothing more overt than that. And we made note of the fact that he did have a history of what we call GAD, generalized anxiety disorder. On review of systems, he was eating, sleeping okay, using his CPAP. He did complain of some hip pain on the left side and walked with a limp, but his balance was okay. He had had no falls. Falls are now the #1 reason for admission to nursing homes. And he said his energy level was reasonably good. He was an only child. Parents died young. He was married for 40 years. He did have, as a family resource, his wife at home, but also 2 sons that lived nearby. A high school graduate, worked in the landscape business, and retired at age 62, a little over 3 years ago. And he was receiving medications for his medical problems that included the ones that we mentioned: gout, the arrhythmia, his hyperlipidemia, blood pressure. He was also on a low dose of an antidepressant, which may have been used either for depression or anxiety, and antiplatelet therapy to prevent clots, and also a low dose of a pain medication.
So, George, a couple of things strike me about this case. One, of course, is his very early onset, 62, I guess, when symptoms appeared. Another is the many risk factors that he has. He's got the atrial fibrillation, hypercholesterolemia, hypertension, all of which can contribute to cognitive impairment. He's got the chronic obstructive sleep apnea, as well as pulmonary disease. He's on a pain medication. And interestingly, given his early onset, his family history is uninformative because his parents died early, and they might well have had dementia had they lived longer. What is the constellation of symptoms that bring patients to us and are likely contributing to their cognitive impairment?
Yeah, I think those are excellent points. So let's kind of move on to our next graphic, our next slide, as we kind of look at the chronology of events with our hypothetical case. All right, so the first visit that we had, this was an in-person visit with Mr. K.A., was in the right after New Year's, early January of this year. And as you can see on the mental status evaluation, he was alert, thin, age-appropriate, somewhat anxious gentleman. He did admit to having some mild anxiety, particularly because he was new to the nursing home. And, it's not easy to adapt to nursing home life, as we all know. His speech was clear and goal-directed. He was not clinically depressed. On the St. Louis University mental status, which is very similar, a 30-point cognitive scale to the mini mental state exam, he scored a 24 out of 30, which would put him in the early dementia range. And our impression was that he did indeed have early onset autosomal dominant Alzheimer's disease and met criteria for generalized anxiety disorder. Our recommendations were relatively basic. We recommended weekly psychotherapy, and we were fortunate in our setting to be able to have someone that comes to the facility, a psychologist, as well as an advanced social work therapist who can provide weekly counseling and psychotherapy for patients like him. And he was prescribed a low dose of an anti-anxiety medication, not an urgent situation. We said, well, we'll kind of see him back in a month, about 4 weeks. So we go to our next visit, which happened about a month later, early in February of this year. And, good news, anxiety was slightly better. Maybe we're doing the right kinds of things with the psychotherapy and the medication. But we wanted to see him do even better, so we recommended a slight increase in his anti-anxiety medication dose. And we, of course, wanted him to continue in the psychotherapy, which he was evidently doing quite well in. And we would see him back in about a month. So we did see him back actually in about 3 weeks. We were at the nursing facility. These are all in-person visits. And it was a very brief follow-up because he was doing pretty well. We were happy. Then about a month thereafter, in fact, almost exactly a month later, came the March 21st, came the COVID-19 lockdown in St. Louis at all nursing facilities.
So I'll pick this up because the COVID has had such a dramatic effect on our patients. And that is both the remote visit that George will talk more about, but also the face-to-face visit. And here I'm actually showing a picture of myself in the clinic with a mask and a face protector, a face shield. And you can see how much it alters my appearance. And I think this is a great challenge to our patients with anything more than the most mild type of cognitive impairment. Of course, I'm wearing a mask, the patient is wearing a mask, the caregiver is wearing a mask, the sounds are muffled. I found it very difficult now to decipher the facial expression of my patients, to understand the nonverbal communication as well as I could in the past, because we're simply obscuring so much of the emotional message that occurs around the face. I recently had an experience where I was in the clinic and the patient's mask came off, and then of course, he has visual spatial problems, so I couldn't get his mask back on. I had to help him with that. Of course, we're trying to maintain social distancing. So the delivery of care in face-to-face settings has been profoundly altered. And of course, we've had to modify many of our procedures. A lot of our rehabilitation interventions were suspended for a while the initial shutdown occurred, and then they've gradually been reinstituted, but at a lower volume, with social distancing, with mask in place, with lots of hand washing. So the experience that the patient and the caregiver are having profoundly different under the COVID circumstances compared to the pre-COVID time. And I think we have to be thinking about that. And particularly, what is the influence then on the neuropsychiatric dimension of the patients that we're caring for?